This video presents the overview of the changes in sitting that this boy had over 2 years of his ABR rehabilitation program. On the left, we are seeing that starting initial level. On the right, we will be going through the pictures that demonstrating the way that he has changed. I believe that the difference is quite obvious, sort of speaks for itself, but in this particular level of videos, I want to focus on meaningful specifics, on explaining the details, explaining the way we are analyzing the situation and the way that those micro changes occur and accumulate and transform. And I hope that this is going to be not just the information about the ABR, but it's going to be more the education about their weight bearing and movement function in children affected by the brain injury, which is going to help you to understand your own kids better, not just evaluate and see for yourself the results of ABR work. Let's get some details and some specifics. So on the left, we're seeing a typical picture. Hyperextension. You're seeing my level of support is quite high, nipple level, but still when he's trying any sort of activity, he's just arching backwards, having this typical W position of the arms. If I make the transition of support to a more comfortable for him, going higher, so he relaxes and just folds forward. So this is the maximum level of support, and even with the maximum level of support, he's unable to do anything, unable to control his position because the head just falls, right? And on the right, you're seeing that 2 years later, he controls the entire upper body, and the level of support is being just at the pelvic girdle itself. So we went down significantly from the shoulders, from the level where he didn't have the control of the things before, all the way up to the shoulders, right? Even the shoulder support didn't help him. Now we have moved through the phase of the upper chest support, mid chest support, lower chest support, abdominal support to the level of the pelvic support. And that's a very straightforward thing to understand. One cannot just jump and make a leap from this to this. It's a transformation. And if you're looking for the independent sitting in the long run, well, and this is where we have achieved the independent sitting in the, say, tailor sitting position, right? Well, that requires the transformation because this is the maximum level of support, and if that maximum level of support doesn't work, so things have to be worked clearly on the way down. So that's hyperextension, and this is an even more accentuated hyperextension. So let's get further into the details. Just giving you several views for the comparison, which are going to help you to understand the ongoing difference. And I think the most important, the most interesting for you would be to understand the nuances of the things that were there before. So that's the overall drop. This is the drop of the head, even when the support level is the highest. So this is another very, very important thing, the support by a single arm, right? So you're seeing that even with the suspended arm support, he's completely unable to use the arm for to help himself, to assist the counterbalance. And that is really important because that gives us this illustration of a very, very essential idea. One can divide this development or the fundamentals at 3 main domains. Domain number 1, that's the segmentation, meaning the selective mobility of individual body elements. It's common sense, it's not difficult to understand. Level number 2, this is the weight bearing, the ability to control the major elements of the body against the weight, control the weight, sort of posture. And it's the level number 3 where one can talk about the selective movements, which would be related to the intentional selective functions, the voluntary functions, the coveted voluntary functions that every parent wants to see in their quadriplegic child. But the key educational emphasis of this video is to help you to understand that training alone, thinking of sending signals, is not enough. It's not going to work if those previous blocks, previous domains of the segmentation of the weight bearing are not there. Obviously, in this position, how could he use his arm if it's not movable? So that's a very, very simple thought. So obviously, if we want major improvements, first one has to see the mobility, and that mobility has to come from strengthening, not from forceful abuse of a chair, like invasive procedures. And then those levels of built-in strength, they have to accumulate and bring their weight-bearing level. And on top of this, once those two fundamental blocks are there, then one can start talking about the actual level of the hand function, leg movements, and so on. Selective, purposeful movements. So that's the key idea that we want to illustrate. And we'll go into greater detail of this in those selective videos, which will be kind of showing you intervals of change over sort of several months, not at the larger 2-year scale. So with this in mind, let's get back into the details once again. So this is the background. Lack of mobility, fixed, fused, unable to move. Even supine, he's locked. So everything else stems from this. You see, one another aspect that I want to understand and want to highlight, that it's not just the tests that we do that show the challenges of this boy. Even when his mother was handling him, she had serious troubles, right? It was hard to position him. He didn't have a sitting platform. He didn't have a counterbalancing. He couldn't relax. His head was arching backwards. The arms were stiff and so on. So even beyond the tests, he was really in significant trouble. So this is very, very illustrative, this hyperextension. So, and that's what I want you to see and want you to understand. You see, once I'm doing this simple test, I'm just shifting the child left and right? And what we're seeing, he's just going on as a unit. As a unit, he just falls without having any counterbalancing whatsoever. The legs and the pelvis, they move as a single unit. You see, there is no selective mobility between them. So without this selective mobility, one shouldn't be, like a clairvoyant to understand that he is not going to be able to counterbalance. You're seeing that in the beginning, with the low level of support, the boy just fell down, right? He's being unable to do anything productive. And now it's a different level of strength, which allows him to control. Over here, we can see another key element, right? You see, as I'm moving him by the trunk, the legs are moving together as a single unit. And please note that the movement of the head goes as a unit as well. He doesn't have any room for selective movements of the arms neither. So he is one fused block. And that happens whether I move him by the upper body or whether I move him by the legs, doesn't matter. So wherever I try to move him, he responds as a unit. And you see, that's the view from the back, same story, no counterbalance. And this is what I want you to see here. Please have a look. You see, he moves his head on his own, and you can see very well these mini movements, the selective movements of the head in respect of the rest of the body. And when he's being moved passively, you can see that the independence of the head movements from the trunk is very, very clear. So that's one of the key basics, one of the key elements that one has to understand. Without this on-the-ground fundamental change, these major transformations in sitting, they couldn't have happened. Things are logical, and there are reasons. Blocked child, the child without segmentation, the child without selective mobility, is unable to utilize signals, whatever, to be able to control his positioning. That's a very simple thing. So before one can expect any control, one has to provide the basis, the strength, the ability to have the selective movement of the elements. And only after that, any conversation about control and purposeful use starts making sense. I hope that's resonating. Just note this difference in the mobility. You see, that's blocked, unable to move, and this is what we are seeing today. rotational mobility. So that's the reason why, that's the fundamentals. These are the fundamentals that allowing this young man to be able to actively engage the counter movement. Obviously, in this situation, with those levels of stiffness, with these levels of complete kind of lack of mobility and fusion, superficial fusion, expecting him to counterbalance would be completely illusionary. And that's the reason why, you see, when he's being placed into the sitting position, he just drops. He just drops without any counterbalancing, right? He's completely helpless in this position. I'll make one more remark. Sometimes people ask, well, why didn't you test, say, the tailor sitting position earlier? Well, fact is, it wasn't possible. You see, when I was trying to move his leg, it wasn't possible to bend it without bringing discomfort. That clearly indicates by itself that tailor sitting position wouldn't work, simply for the reason that, the legs were just stiff, stuck, and so on. And if you look throughout all the other tests and positions, whether when he's lying on his back or when he's sitting, supported obviously at the maximum level, all the time we see these rigid, unbendable legs. Another illustration of the same story, right? I'm moving him by the trunk, the legs just like move, similar to, say, a mermaid tail, without any selective mobility within the pelvis. So that's why tailor sitting was unattainable, and I will show the better details of this later in the selective video dedicated to transitions of this specific element. So on the one hand, we've seen him falling backwards helplessly. On the other hand, if I was just changing his starting position a little bit differently, well, what was happening? He was just folding and flying forwards as a unit. But you see, important, interesting thing here. As he folds forwards, he doesn't have any mobility in his back. He just goes as a unit. No counterbalancing, front and back. So we've seen him being fused rotationally, we've seen him being fused laterally, and we've seen him being fused in the front and back movement. Let me just illustrate. So that's the demonstration of lack of any counterbalancing laterally, and this is the demonstration of lack of any counter rotationally in a transverse plane. So without being able to move neither to the front nor front back, left right rotation, left right tilting, well, he wasn't able to do anything. He wasn't having any background basis to be able to control the sitting position, even if he were to have the best image of what he has to do. He was simply unable to execute it. And this is the constraint, the limitation that often escapes the sort of, say, neurological signal-based idea about the motor functions. And this is the key element that we want to bring to your attention into the ABR throughout this advanced biomechanical rehabilitation. Biomechanical standing for our focus on the biomechanical components, on the nuts and bolts, where we invite you to analyze them and actually point out that without the tools of improving the nuts and bolts, the elementary mobility, elementary strength, it is really not much of the opportunities to improve the condition of a child, because again, he's at 3.5 years of age, having at least 3 years of really dedicated rehabilitation program from his mother. She's a pediatric doctor, so she knows the best available in that sense, but that didn't work for him. And the opposite, once we started working with details throughout ABR, well, those details started to convert into the larger things. I'll deliver a little more of the highlights of this very important test, supported sitting, because that's one of the starting points. Supported sitting with the one arm suspended. You can see that for him here, it didn't work at all. Obviously, things have transformed dramatically. On the left, I'm supporting him by his stronger, better right arm, but that doesn't work. On the right, he's being supported by the weaker left arm, and you can see that he controls his body position and moves the right arm selectively without any challenge to his sitting placement. So that's a significant transformation, and as I said earlier, it's based on the improvement of the elementary components, which has been achieved on the step-by-step basis throughout their daily work. There's no magic, no miracle here. It's the day in, day out work which sort of drop by drop improves and strengthens the child, and then gradually translates into those accumulation of the minor changes which actually then bring the milestones of the transformation. Let's have a summary of the key ideas essential for the analysis of sitting. First of all, independent sitting, the sitting without the support and the ability to counterbalance, does not appear out of nowhere. It is impossible to sort of jump from this high level of support and complete lack of counterbalancing into the unsupported sitting where the child has the counterbalance. You need to pass through the stages of the reducing support. Maximum level, then lower down, and lower down. In that sense, the upper chest support, the mid-thorax support, the abdominal support, the pelvic support, and then the lower level support, and so on. So that's the essential thing to remember and understand. Expecting that a person can jump from this into the independent sitting is unrealistic if you think about training and signals. Another straightforward avenue for evaluation of sitting is the evaluation of the necessity for the arm support, suspended arm support. If the child doesn't have any, that means that there is a very poor weight bearing of the entire trunk. And obviously, there is a need to get through the stages where the need for their extra suspended arm support would be consistently reduced. That's a very clear path of evaluating and reaching the progress. 3. Tailor sitting stage is absolutely essential. If the child is rigid and doesn't have a sitting platform, it is impossible to expect any quality independent sitting. That's not compatible with sitting, this rigidity and uniform single block movement of the entire upper body and the legs. 4th simple big idea, no counterbalancing without the segmentation and the selective mobility. This is the source of the possibility to adjust and get the counterbalance, the mobility of the entire upper body, and of course in all 3 directions as I've pointed out earlier. And of course any expectations of sitting without the head control are completely unrealistic. Again, on the left you see none of it, and on the right you can see the independent head movements. Same refers to the shoulder girdle. Blocked, immovable arms are incompatible with the counterbalancing and sitting. Shoulder girdle mobility is absolutely paramount and necessary for the counterbalancing and stability in the sitting position, whether it's edge sitting or tailor sitting position. And of course, expectations of any hand functions without the solid control of the upper body are very much unrealistic and ungrounded. Again, no signals will ever make it without the physical executable chain of the biomechanical elements. I hope that the examples of progress and transformations achieved by this boy through the non-invasive strengthening ABR methods have been good enough illustrations for you to understand the importance of these principles. And the further illustrations of these principles are going to come in the even more detailed overviews, where instead of this comparison of 2-year interval, we are going to get into the analysis of sitting with the space of a few months in between, where you'll be able to see those details even in better nuances and step-by-step components. Thank you very much for watching, and I hope that this educational journey has been rewarding and interesting.